Hi, everyone. Thank you for joining us, and good morning. My name is Michael Stewart. I work with the OI Foundation as the Director of Education. We're going to get started in just a few minutes. Thank you for joining us at the first ever OIF virtual conference. The session this morning is going to be on the basics of OI, as you can see on the slide on the screen, genetics and clinical management with Dr. Joan. If your microphone is on, please mute yourself. Thank you so much. This is so that we can hear the speakers talking, we can get the medical information, and it's just clear for everyone. We totally understand that dogs bark, doors will slam, babies cry, unintentionally. Also, I want to do a few other housekeeping announcements. We ask that, so if you would like to use closed captioning, that is provided in the info screen at the bottom. You will see a CC button, and then you press show subtitle, and you'll be able to have closed captioning throughout the entire session. Also, if you have any questions throughout any part of the presentation, please put them into the Zoom chat feature below. And during the Q&A period at the end of today's session, we will do our best to get to all of your questions, or as many questions as possible. Again, I want to thank you all for coming today. One also final announcement is that during this session and during all sessions of the OIF's virtual conference, our goal is to provide the best medical information possible, the most up-to-date information, the most accurate information. And that means we can answer we and the speakers can answer many questions. What we cannot do is practice telemedicine. So what that means is while we can provide the best information possible about OI, we cannot answer individual treatment questions or give specific recommendations. To those of you who are just joining us, again, thank you so much. We would ask that everyone please mute their microphone just so that we can hear the speakers talking. Thank you so much. And again, if you have any questions or comments, please put them into the chat bar, and we will do our best to get to them in a timely manner during the Q&A period. With that being said, I'm going to introduce Tracy Hart, the CEO of the OI Foundation.
Thank you, Michael. Good morning, everyone. It's so great to, quote unquote, see so many of you. I'm scrolling down and looking at so many familiar names and faces, and just so happy that we're all here together this morning. Unfortunately, this is not the 50th anniversary celebration that we were hoping for, where we could all be together. But again, as Michael said, you know, glad that we're here together in this way to kick off the virtual conference with this really exciting presentation, Basics of OI, Genetics and Clinical Management. Just a couple of things I wanted to mention. First of all, I hope everyone is doing well and you're staying safe, and that you're visiting our website if you need information during this health crisis. We're here for you. That's our job. We want to make sure we're getting you the best information possible. The other thing is, I see some familiar faces, as I said, and I just wanted to quickly note a couple of people. I see Dr. Gloria, who is the chair of our Medical Advisory Council there, and so glad that Dr. Gloria is here this morning, and many members of our Medical Advisory. OIF staff person, Mary Beth Huber, is joining us this morning as well. So glad that you're all here today. The official welcome session for the conference starts immediately following this session. So we do have a hard stop for this session, and I know there are going to be a lot of questions, so I'm almost done talking. But hopefully you've registered for the welcome session as well, and all the other sessions for our virtual conference. It's the first time we're doing this, and so we're sort of learning some things as we go along, but we're just so happy to be together this morning. And with that, I am going to introduce our speaker. So as many of you know, when we have our national conferences in person, we have this session, the Basics of OI, that we provide for people with a new diagnosis, or maybe someone in your family has a new diagnosis, or someone that just wants a refresher. And so that's always a popular session at our national meeting. Today, this morning, it's very popular. As you can see, we have more people joining us as the minutes are going by. And we have a very exciting and wonderful speaker, who's going to present this morning. So I get to introduce at this time Dr. Joan Marini. She is the chief of the section of heritable disorders of bone and extracellular matrix at the National Institute of Child Health and Human Development, NICHD, at the NIH. She leads the NICHD Osteogenesis Imperfecta research program, in which clinical and bench research are fully integrated. Her lab generated the brittle mouse model for type 4 OI and the PPIB null mouse for type 9 OI, and has played a leading role in the consortium for OI mutations. In the last 10 years, her group has been a leader in the exciting new developments about rare and recessive OI, which have revealed new genes not previously understood to be critical to normal bone formation. Dr. Marini received her MD PhD in the Medical Scientist Training Program at the Johns Hopkins School of Medicine. She completed training in pediatrics at Johns Hopkins and Georgetown University Hospital. She did clinical genetics specialty training at the NIH Inter-Institute Genetics Program. She has twice been awarded the NIH Director's Award for her work on osteogenesis imperfecta. Dr. Marini is a member of our Medical Advisory Council and a former chair of the Medical Advisory Council. So with that, Dr. Marini, I'm going to pass it on to you.
Well, good morning, everyone. This is quite a crowd, which is very nice. And you'll get to witness my first Zoom lecture, which therefore might have entertainment as well as informational aspects to it as we handle the technology, especially the new government version of Zoom. As Tracy mentioned, the target audience is individuals new to OI, and looking at the list of registrants new to OI. So you're certainly welcome if you want a refresher, but this will be the material that I would cover with a new family at the NIH during the first visit, usually over a couple days, but I've crammed it into 1 hour, which means that I'll start with a refresher on your high school class on genetic inheritance. Then I'll move on to OI genes and classification, and hopefully some time for management. This is a lot to cover. If you find one section challenging, please just hang on for the next section. And there is one bit of housekeeping. I will have several photographs of patients in my slides. I use them with permission. Many of them have already appeared in medical journals, but to anyone who's clicking along, taking pictures of my slides, please be respectful and don't take pictures of the ones with patients in it. Okay, off we go. Oh no, it's not advancing. We're back to.
Sorry, everyone, some minor technical difficulties.
We've already started with the technical. Okay.
It happens. And this is the same when you click on your mouse.
I see. Will this set me up for, yes, okay, good. I had to initiate, okay. So, osteogenesis imperfecta is a Latin term that's not difficult to translate. It refers to imperfect formation of bones, osteo. And OI is a collagen-related bone dysplasia, and you'll see what that means in a few moments. The hallmark features of OI are an easy susceptibility to fractures and bone deformity, and also growth deficiency. OI has an incidence of about 1 in 15,000 to 1 in 20,000 births, which puts it in an intermediate category. It's not so common that your friend or neighbor is likely to have heard of it, but it's also not one of the super rare 1 in a million birth genetic conditions. So I call it medium rare. Most cases of OI, 80 to 85%, are caused by defects in the structure or the quantity of a molecule called type 1 collagen. And these cases have dominant types of OI. Of course, these types were always there. It's just our understanding that's new. And in general, they're caused by mutations in genes whose protein products interact with collagen to help it fold, or for processing it, or for cross-linking, or modifying it. And almost all of these types have recessive inheritance. So let's start with that quick refresher on genetic inheritance that will come back to you from high school. Okay, so remember that we all have 2 copies of every gene that isn't on a sex chromosome. So say we're talking about a dominant condition. This man may have OI caused by a dominant collagen defect. That means he has 1 gene copy with the mutation, which is an X here, and 1 gene copy with the normal sequence. And in dominant conditions, one way of remembering it is that in dominant conditions, the effect of the mutant gene dominates over the normal gene and results in symptoms. You have the condition. You're not a carrier. He has the condition. Now, if he has children with this woman who has no collagen problems, this diagram shows the statistical outcome for their children. All of her eggs have normal collagen genes, and so do half of his sperm. So 50% of their children do not have the condition, but the other half of his sperm carry the collagen mutation, and the half of his children who inherit the gene have OI because the man's mutant collagen gene dominates over the normal collagen gene. Now, it looks like, oh, okay, I've had a child with OI, and I hear there's a 50% risk, but now I've had my affected child, and now we're good to have children who do not have OI. No, this outcome is statistically 50-50 for each pregnancy. What about recessive inheritance? To have a recessive condition, both copies of the same gene need to have a mutation because these defects don't dominate over a normal gene. So if this man and this woman have a mutation in, that's the X here, in 1 copy of the same gene, generally for recessive conditions, they're going to be medically healthy. They wouldn't know they have this because the normal gene makes enough to use. And these people would be said to be carriers. And here's what happens if they have children together. Statistically speaking, 1 in 4 children will inherit both normal gene copies. That child does not have the condition and is not a carrier. Another 1 in 4 children will inherit both mom and dad's mutant gene copy. That child has the condition. The other 2 will either get mom's mutant copy or dad's mutant copy of the gene, but not both. So they're carriers like their parents. They don't have the condition. And that is why you'll hear kind of a statistical summary that in a recessive condition, 1 in 4 children will be affected, and of those who are not affected, 2/3 will be carriers. But again, that's an overall statistic for each pregnancy. The proportion of risk repeats itself. Then there's another type of inheritance that comes through the mother and only sons are affected. This is called X-linked recessive. The most famous example of this condition you've probably heard of is hemophilia. And there's only 1 type of OI with X-linked recessive inheritance. And at this time in the world, I know of only 5 families with this condition. There would presumably be more, but I only know of 5. But I'll tell you a little bit so you have the context. In this situation, the carrier mother is healthy because she has 2 X chromosomes. So the normal gene can compensate for the gene that, say, is not making a sufficient amount of the protein. Statistically, half of her sons will be affected. Remember, they inherit the Y chromosome from their dad and the mom's X chromosome. And if the X chromosome has the mutation, then they don't have a second X chromosome to compensate. The daughters or granddaughters of this couple who inherit the mutant gene are carriers like their mom. Now, perhaps you're feeling confused at this point, or likely you're feeling confused. But one reason you might be feeling confused after what I've said is that there's, suppose there is no history of OI in your family for multiple generations. And they likely have a collagen mutation, statistically speaking. And that's, I've just told you, a dominant condition. How could they have a dominant condition? Wouldn't it have shown up in your family before? The most common way for this to happen is a new mutation. What this means is that one sperm or one egg that got together at conception, when the DNA was being copied, and now the child has a new mutation. The parents don't have that mutation, and therefore they're not at increased risk for a second child with OI. They have the population statistical risk for a second child with OI. The affected child with the new mutation, when they grow up, has a 50-50 chance of passing it on to their offspring at each pregnancy. There's another way for dominant OI to appear suddenly in families, and this is called mosaicism. And in this situation, one parent would be a mosaic. And the mutation would have occurred early in the embryonic development of that parent. And this slide indicates the mutant cell by making it blue. So one cell has the mutation. Now, all the other cells that rise from that mutant cell are also blue. They're also mutant, and all of the other cells are normal. And then you get this kind of patchwork of tissue where tissue or sections of tissue that arose from the mutant cells have the mutation, and other tissues do not. Usually mosaic parents are not affected or only very mildly affected. They have no reason to suspect they have a genetic condition. Maybe they had a fracture as a child, but that's so common. And they have really no reason to suspect they have the condition until the full clinical form appears in their child. The difference between a new mutation and a mosaic is that mosaic parents can have additional affected children because by having one affected child, their body has shown that the mutation is among their germ cells. So this is why I always recommend that parents as well as children get tested. This slide lists some of the most common manifestations of OI. Keep in mind that not everyone will have all of these manifestations, and some of them don't even present until adulthood. Many of them you know about. So we have bone fractures and deformity and low DEXA bone density, growth deficiency, delayed motor milestones, mobility issues, scoliosis. Hearing loss tends to come in later. Dentinogenesis imperfecta is the tooth manifestation of OI, a blue or gray hue to the sclerae, a relatively large head. Generally, it's not true macrocephaly, but is large for the head because of the growth deficiency. Basilar invagination may be new to you. This is stem. It may rarely impinge on the brain stem, and that fortunately is rare because it's serious and requires neurosurgery. One thing that's not rare is respiratory issues. Respiratory issues, not fractures, are the most common cause of death in OI. And I think lots of people with OI learned about this during coronavirus, that they might not be at increased risk of getting infected, but they might have more serious, we felt they were potentially at a more serious risk of having a severe case, and hopefully everyone took precautions. And the respiratory issues occur in OI for two reasons. One is structural, that is, the chest wall may be abnormally shaped. Could be a barrel chest, a sunken chest, which we call pectus excavatum, or excavated chest, scoliosis. Another reason is not the chest wall, but is the lung tissue itself. Lung tissue contains type 1 collagen, so tissue structure and function can be abnormal even in childhood and eventually lead to cardiopulmonary issues and even death. You probably don't need me to tell you that OI is highly variable, both clinically and genetically. Clinically, mutations in collagen cause the full range of clinical severity, from lethal in infancy to barely detectable in adulthood. Even people with the same mutation may have very different severity. A very important feature whose mechanism is something my lab is working on, and I presume other labs. OI is also genetically variable. That's a bit different from being clinically variable. We call this genetic heterogeneity, and this term refers to the fact that defects in many different genes can cause OI. So this says most cases caused by mutations in type 1 collagen. True, but now there are over a dozen other genes that have been identified to cause OI. So OI is referred to as having genetic heterogeneity. Okay, let's start. That's your genetics class. Now we're going to apply it. Let's start by looking at the clinical features of OI caused by defects in collagen. The types 1 to 4 were originally part of what's called the Silence classification. That's how it's pronounced, not silence, Silence. You may have heard this term. It was formulated by the Australian geneticist David Silence. And when David made his classification, the an issue of confusion into the OI community, because he chose not to name the types in order of severity. So type 1 is the mildest form, caused by a quantitative defect in type 1 collagen. You make less collagen than you should, usually about half, but all of the collagen you make is structurally normal. And types 2, 3, and 4 are caused by structural defects in collagen, and they range from the lethal type 2, the progressive deforming type 3, and the moderate type 4. So if you're going from severe to mild, you need to think 2, 3, 4, 1. Okay. This is the X-ray of a newborn with a type 2 OI. And you can see how abnormal these bones look. The leg bones especially are crumpled. They're not normally sculpted or shaped. Each of these puffs here is actually a callus where a fracture is healing. If you look at the rib cage, you can see that the top of the rib cage is quite narrow, and I don't know if it shows well, but you can see essentially a little puff of callus on every rib, and some ribs sadly have 2 puffs, so, or 2 calluses. So this child is so severe that all ribs were fractured in utero, and the most common cause of death for type 2 OI infants is respiratory insufficiency. Here's an example of the famous blue sclerae. I cheated, of course. I chose a strikingly blue one. Usually they're not quite so blue, although I have seen some so blue. And many types do have some degree of blue sclerae, but the more intensely blue ones are almost all associated with collagen defects. And there's one grouping of OI types that are clearly associated with white sclerae. Here's a set of x-rays from a child with a type 3 OI, the progressive deforming type. Clinically, these children will have a relatively large head with a prominent forehead, not just tall, but sticking out a bit. We call that bossing, and a triangular face. They may have a chest wall deformity, bottom. And as you can see on these x-rays, the leg bones are severely bowed and the bones have a washed out look. Here's a fracture callus. Bowing can result after a fracture, but in type 3 OI, often the bones are so soft that just the pull of muscle on both ends of the bone will cause bowing. And you'll also notice that these long bones look better than the bones I just showed you of the type 2 OI infant, because they have a more, they're bowed, but at least they have a sculpted shaft and a little bit of a flare at the ends. On the right is an image of the spine. You can see 4 or 5 compression. This is a lateral image of the spine. You can see 4 or 5 compression fractures of the vertebrae. These are the bones, that little bones stacked on each other to make up the spine. These compressions have occurred even before the child is able to sit or stand independently. Most type 3 OI children will develop scoliosis. After surgery and physical therapy, and maybe after medication, individuals with type 3 OI generally use a wheelchair for community mobility. Most do have transferability. Many stand and even walk a bit at home or cruise. Most individuals with type 3 OI now are living well into middle age, some older. Sadly, this child is no longer with us. They passed away after multiple pneumonias, which brings me back to reminding you how important the lungs are in OI. And now we have an X-ray of type 4 OI, the moderately severe form. And now the bones are starting to look more like what you expect to see for long bones. They have a more normal shape. There's still some bowing. The cortex is very thin, and there's a washed out look associated with low bone mass. Clinically, the head may appear relatively large. Generally, it's not truly macrocephaly. They may have a tall forehead, but less prominent than in type 3. You can see that the legs look longer than in the more severe types, and the chest shape is better. Individuals with type 4 can generally expect dozens of fractures during their lifetime. Most can walk independently or with a walker or a cane, or often after orthopedic surgery. Almost always they're short for age, falling below the normal growth curves. So short stature or growth deficiency keeps coming up on that list of hallmark features. It's one of the most consistent and striking features of OI. Essentially, everybody with type 3 has a growth deficiency issue, and most type 4 OI fall off the CDC curves. Many people with type 1 OI may not meet the formal criteria of growth deficiency, but they're typically shorter than same gender siblings. It's always been a bit of a mystery why people who have OI are short. Generally, skeletal conditions that affect cartilage cause short stature, but not so much those that affect bone. And as we now understand it, the cause is multifactorial. There can be some contribution from scoliosis and vertebral compressions, lower limb deformity. Severe OI may have a radiographic feature called popcorn calcifications. Believe me, some radiologist named it. He must have been hungry, but it does kind of look like popcorn. And this can cost quite a few inches of growth, even 4 or 5 inches of growth. The progression of cells in the growth plate can be slow, and bone tissue can be resistant to hormones in the growth hormone axis. So don't be worried about this busy graph. We're going to walk through it. At the NIH, we looked at the full growth patterns of 100 children with types 3 and 4 OI caused by mutations in collagen. And we found that the greatest factor determining height is OI type. That's more important than gender and much more important than the chain of collagen in which the mutation is located. So here you see that the blue and green lines of type 4 OI boys and girls is always greater than the red and purple lines being growth curves, sorry, of boys and girls with type 3. So type more important than gender, but gender still plays a role within type. The blue line for the boys is greater than the type 4 girls, and the type 3 males are greater than the type 3 girls. The third panel on the right shows no significant difference between the lines, and that's because it's showing us that the collagen chain in which the mutation is located does not make a difference in growth patterns among living children. Oops. That the data from these 100 children was used to generate something that I think has been needed for quite a while, OI-specific growth curves for type 3 and 4 OI, boys and girls, for length, for weight, for head circumference. And these curves will allow you, your pediatrician, your geneticist, to see how your child compares to other OI children. You already know that they're shorter than kids without OI, but are they, is there something to worry about? Are they not doing as well as other OI kids with the same type? Maybe they're doing better. It would be important to know. And so these curves are published. The reference is at the bottom. They're available free online, or you can write to me if you or your pediatrician have trouble accessing the journal. Okay, so now brace yourselves. Now we're going to shift gears. This is the collagen biochemistry course. Brace yourselves. But it'll be great because it's about collagen, one of my favorite proteins. So this is new to you. Don't be discouraged. This is the kind of thing that it helps to hear a couple of times. Each time you will understand a little bit more of it till finally you think that it's obvious. Many people, when we talk about collagen, start out by wondering whether we're talking about the same collagen that they see advertised in shampoos, soaps, and face creams with collagen. And the answer is yes. Biochemically, we're talking about the same collagen, except of course, the collagen in those products is derived from animal skin. And this is a diagram of type 1 collagen, a famous Darwin-Prokop diagram for the docs. It's a big protein. It's too big to be absorbed by your scalp and skin. Sorry for the ding of the cosmetic industry. And it is the major protein of the extracellular matrix of bone and skin. And you can see that it has 3 chains, therefore we call it a trimer. The chains are not identical to each other, so we call it a heterotrimer. And it contains 2 copies of the alpha-1 chain and 1 copy of the alpha-2 chain. Because when you get your collagen results back, it's going to say you're in Col1A1, that's the alpha-1 chain, or your mutation is in Col1A2, that's the alpha-2 chain, and it is important to know. So these 3 chains are twisted together, and this central portion, which is over 1,000 amino acids long, is it is synthesized as a with globular extensions at both ends, this, and then here and here. This is called pro-collagen. That's the pro molecule. And the helical portion of the alpha chains are similar to each other. They're composed of a repeating tripeptide, GlyXY, 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 over 300 times. The gly is glycine, which is the smallest amino acid. The X is often proline, and the Y is often hydroxyproline. I'm going to go over this again with several other slides. And you need that glycine at every third residue because, as I mentioned, it is the smallest amino acid. This is a helical structure. The space inside the helix is very constricted. What can fit in there? Only a glycine can fit into the very tight center of the helix. So most of the collagen structural defects that cause OI involve a mutation that makes the DNA code for a different amino acid where a glycine should be. And this amino acid is larger than glycine, so it has trouble fitting into the helix, and it interferes with helix folding. And you can see two more things on this diagram. You see all these little things sticking off of collagen. That's because the collagen is modified extensively during assembly by specific enzymes. We'll get to that. And the second is that these propeptides have to be removed or processed before the collagen can be incorporated into skin and bone. So this diagram shows in more detail the modification of collagen during assembly. Down here are the collagen chains. The alpha 1 chains are in yellow, and the alpha 2 chain is in this gray. And they've come together at one end, and they're just starting to get ready to twist into the helix. And the helix will form like braiding a braid or zipping a zipper. It starts at one end, always the right-hand end of the diagram, called the carboxyl end, and it finishes at the left end. And there are enzymes. One is named lysyl hydroxylase 1, this light lavender here. Here it is sitting on collagen. It adds a hydroxyl group to many of the lysines up and down the chain, and then sugars are added to that hydroxyl group. And there's another enzyme, prolyl-4 hydroxylase. And it also binds to collagen and hydroxylates prolines. And the meaning of the name is that it hydroxylates proline at what is chemically called the 4 position. And these enzymes are busy up and down the chains modifying residues. And enzyme complex, the prolyl-3 hydroxylation complex that targets only one proline residue per chain. And now you know that the name means that it modifies the 3 position of the proline ring. And if you know your or your child's OI causing mutation, that result likely came from a sequencing test. But it used to be done by a protein test, rarely done now, but I'm showing one because of what it illustrates about collagen folding and modification. So say you have a glycine substitution at this very near the carboxyl end, the right-hand end of the protein. The chains come together and they try to get folding, and whammo, the first thing they've done is hit a roadblock. And it takes time to get around that roadblock. And during that time, those modifying enzymes, they're busy adding extra hydroxyls and sugars to the collagen, and they, on a separation gel, make the chains look bigger. What if the modification, what if the substitution is in the middle of the chain? Well, then only half of the chain is available to the modifying enzymes to add extra hydroxyls and sugars. You can still see that it's bigger, but not as big as the carboxyl end. And at the amino end, it's much more subtle, but can still be determined by comparison to normal samples. Whether that glycine substitution, so you say you get a diagnosis back and it says Col1A1 or Col1A2, what does that mean for outcome? Well, whether it's located in the alpha 1 or alpha 2 chain, it's position along the chain is a major contributor to what the outcome is clinically. But it's not an absolute determinant. So, for example, a higher percentage of substitutions in the alpha-1 chain cause lethal type 2 than in the alpha-2 chain, but it's not absolute. And within the chains, the map of where the lethal positions are, the upper diagram is alpha-1 and the lower diagram is alpha-2. The maps are different. That makes sense. The sequence is different. They have different roles, but it's not absolutely predictive. In general, the regions that result in the severest consequences are regions along the collagen chain that are important for the binding of other proteins in matrix with collagen. We really don't understand enough yet to say in advance what an we have a glycine, whatever number, to serine substitution, and I would instantly know what the outcome would be. We work instead by comparison. We look at the mutation database to see what the clinical severity of this particular mutation has been in the past. Sometimes all the previous people with the mutation have the same severity, say type 3, but sometimes the same mutation has led to several type 4s and several type 3s and even a type 2. And this must be caused by modifying factors, but we don't yet understand what they are. So everything I've been talking about is up here. Here's the collagen, the modification, the misfolding. And that results in a cascade of cellular and tissue events. The cells that make the mutant collagen have chronic stress. Yes, you're not only stressed, your cells are stressed. And then there is out here in the matrix, there's that disruption of binding sites that I referred to for non-collagenous proteins that should bind to collagen. And then the cells that are making the mutant collagen, because of their stress, their development is delayed or incorrect, and their communication is, bone-forming cells are called osteoblasts, and they generally communicate with bone-resorbing cells called osteoclasts. And this communication is incorrect, and it results in a situation called high bone turnover, where there are lots of osteoblasts and osteoclasts, and it's turning over very fast. And then a crucial characteristic of OI bone is that it's hypermineralized, which makes it more brittle and chalk-like and easy to break. And this is yet another diagram of collagen assembly and secretion. And this one I'm showing to you for the portion at the bottom of the slide, just outside the cell. This egg-shaped structure is the cell, and here's the procollagen that's been secreted. And I want to remind you that the globular portions at both ends of procollagen have to be removed before the helical portion can be assembled to matrix in skin and bone. And when the removal of what we call the propeptides does not go properly, then you get two specific variants on dominant collagen-based OI. First, we'll look at the one at the left or amino end, and then the one at the right or carboxyl end. So the teenagers that you see in this slide have mutations in collagen that interfere with the processing of the aminopropeptide. And they have tremendous hyperlaxity of large joints. This young lady was able to just casually, sitting on the edge of a bed, throw her leg behind her neck because her hip was so loose, and also laxity of the small finger joints. They also have that intensely blue sclera I spoke about, and their laxity is so pronounced, they look like another condition called Ehlers-Danlos syndrome. So we call them combined OI-EDS. What's happening in that situation? Well, at the tissue level, when you cannot remove the propeptide at this end, but you can remove the propeptide at the right-hand end, then what you incorporate into matrix has this globular end still stuck on it. And here it is trying to incorporate into collagen bundles. And you can imagine that this is not good in an engineering sense. These bundles are less stable with all these little blobs sticking out. They can slip against each other, leading to dislocations, and tissue tears. And second, these little extensions are a physical obstruction that makes it hard to add more helices to the collagen fiber. And so the fibers are thin. You barely takes a glance to see that everybody on the left column has fibers that are about half the size of aged match fibers when you look at them in cross section. Now let's turn to what happens at the other end when the carboxyl or right-hand end of procollagen can't be removed because of a mutation, and all of the mutations are known in all of the cleavage sites now. Here we got a very unexpected situation. If the C-propeptide processing site is mutated, then patients have a paradoxical condition called high bone mass OI. They actually have elevated DEXA bone density or normal, not reduced. And this is because they have an increase in matrix mineralization compared to other OI cases. So this graph shows mineralization measured directly on bone samples. And here you can see what concentration of calcium the peak mineralization is at. And this gray zone is a young reference standard of children who don't have OI. And then the red curve is from classical OI with a glycine substitution. And you see that the curve we say is mineralization of the bone, but for these individuals who have a processing problem at the carboxy terminal end, they're represented by the blue curve, which is shifted even further, showing even more mineralization. And when you look directly at grayscale images of bone, you can see these very white areas of intense mineralization. So that's my introduction to OI caused by collagen defects. Now let's turn to other genes that cause OI. And all of these rare forms are connected to collagen in some way. Remember, I said that OI is characterized by genetic heterogeneity. Remember that term from near the beginning of the talk? That's when a condition is caused by several genes. This slide gives you the bottom line message. These are features that are most importantly affected by the rare forms of OI: collagen modification, bone mineralization, and collagen cross-linking. So all of these forms are connected to collagen in some way, which makes it collagen related. Some of the rare forms affect collagen in more than one way. And almost all the rare forms have recessive inheritance. And this table organizes the rare types by gene, listed here, and by inheritance pattern here. AR is autosomal recessive, AD is autosomal dominant. There's an X-linked form. At first glance, this table may look intimidating. Don't be intimidated. I'll give you the cheat sheet over here. It turned out that they were discovered in an order which made it possible to organize them by function. So we have 1 to 4, which is the collagen structural mutations, types affecting predominantly mineralization or collagen modification, or another group affecting collagen processing and cross-linking, and an interesting group affecting osteoblast differentiation, or the bone forming cells. I'm going to try and give you some information to make this easy to remember as I go through some of the types. But if you or your child have one of these rare types, then of course you'll want to learn much more about. With the identification of new OI types, basically the numbering from the Solence classification was picked up as a continuation of Solence 1 to 4. So the next type was called type 5, and then the next type was called type 6, and so on. I'm going to start with types 5 and 6, which particularly affect mineralization. It's interesting that these two types were actually defined before the genes were known using X-rays and histology by Professor Glorieux. So type 5 OI, having told you repeatedly that the rare types are mostly recessive, let me start with the one that isn't. Type 5 OI is the only non-Solence type with dominant inheritance. It's not super rare. I would expect that at least one person listening to today's presentation has type 5, and you can almost make the diagnosis from the X-rays. They have some combination of, because their symptoms are quite variable, what's called hyperplastic callus. Instead of that nice little puff of callus, you get kind of this over-exuberant callus, mineralization of the membrane that's between the two bones of the forearm. Usually you can't see that because it's not calcified, but here you can, and this dense band at the metaphysis, and often they have a radial head dislocation. Essentially, everyone with type 5 OI has the same mutation in a gene called IFIDM5 or Brill. This is a protein that sits on the outer cell membrane with its front tail inside the cell. In normal cells, Brill plays a role in bone mineralization. The mutation causing type 5 adds 5 more amino acids, 5 and 5, at the end of Brill inside the cell and overactivates it. So you get that exuberant mineralization I just showed you. Type 6 OI has recessive inheritance. It's distinctive in that it's not generally detected at birth. Usually the first fractures come after a year of age, and then unfortunately it becomes severe and progressive, as you can see from the X-rays. This form has a time lag in mineralization, time in bone, and an increase in the blood test for an enzyme called alkaline phosphatase in childhood. This enzyme also increases after a fracture, but in type 6 OI, the increase is much greater and it's sustained. So type 6 OI is caused by mutations that block the production of something called PEDF, which stands for pigment epithelium derived factor. And that name comes from the eye. That's odd, quite different from bone. And it's also very well known as an anti-angiogenic, anti-vascular molecule, and even in use to treat tumors by decreasing their blood supply. So it may sound surprising that an absence of PEDF would cause OI. But the key factor is that PEDF is a collagen binding protein, and moreover that the binding of PEDF to collagen in matrix is essential to its anti-angiogenic properties. So types 5 and 6 are caused by very different genes. The clinical severity is quite different, and now the way the bone tissue looks is very different. In type 6, you see lots of unmineralized matrix called osteoids. See these red seams here, and where you should see normal lamellae, instead you see a fish scale pattern. Type 5 does not have increased osteoid, and it has a mesh-like pattern instead of lamellae. But one way in which types 5 and 6 are the same is that their bone cells have decreased production of type 1 collagen. And it's interesting and probably important that the pathways for types 5 and 6 in bone cells interact with each other. When Brill activity here is increased by the 5' extension, it increases the production of PEDF. And when PEDF is absent, the production of Brill is decreased. And several labs are now working to understand the connection between these pathways. Next, I'd like to tell you about the other set of rare OI forms that affects more than a handful of people. This is the group with abnormalities in collagen modification. It consists of types 7, 8, and 9 OI. These types all have recessive inheritance, so we generally expect that there would be 2 carrier parents. I showed you this slide earlier when I was talking about the enzymes that modify up and down the collagen chain, and I mentioned this special complex that does a 3-hydroxylation of 1 proline on the alpha-1 chain, happens to be proline number 986, and 1 on the alpha-2 chain. And this modification must be very important because it has a whole complex of proteins to ensure that it happens. The complex puts a hydroxyl group on the 3 position of the proline ring. So it's named prolyl 3-hydroxylation complex. And it has 3 components. First, there's the enzyme that actually does the hydroxylating. And then there's something called CRTAP. This is the helper protein to survive in the cell. And then there's another protein called cyclophilin B. We've known for a long time that this protein was important for collagen folding. So if a child is missing the CRTAP protein, you have type 7 OI. This is a very severe OI, as you can see from the crumpled leg bones. You might think this was a type 2. From the crumpled leg bones and compressed spine bones. They generally have a chest wall deformity. And what makes OI caused by CRTAP deficiency different from the structural defects in collagen. Here's where the sclera are white, not blue. They have a smaller head size than usual for severe OI and a round rather than a triangular face. And they also have a disproportion of their leg bones. There's a usual proportion between the upper bone, the femur, and the lower bone, the tibia. And in this condition, the upper bone has relative shortening, and you have a feature known as rhizomelia. Unfortunately, these children usually do not survive beyond their second birthday, although I do know of a few children with type 7 who are 8 or 10 years old. In infancy, it's hard to tell type 8 from type 7. Type 8 is caused by absence of the P3H1 enzyme. It shares the white sclerae, the round face, the rhizomelia of type 7. And these types are so similar because the 2 proteins need each other for stability in the cell. So if you're missing one, you're missing this dyad. Type 8 is also very severe with a high proportion of death in infancy. One of the most common mutations causing type 8 originated over 400 years ago in West Africa and is present in the African American community, at least on the East Coast. So this should be a consideration for some patients. Many type 8 patients will die in infancy, but it's much more common for type 8 than for type 7 to have a longer lifespan, living into their teens or 20s with very low DEXA bone density scores, Z-scores in the -6 to -7 range. And the third member of the complex I mentioned is cyclophilin B. It's the gene is called PPIB, but the protein is called cyclophilin B. And patients with deficiency of cyclophilin B seem to fall into 2 groups. There's a group that die in infancy and a group with moderate severity, and this QD obviously comes from the group. Also have white sclerae, but do not have rhizomelia. And this type affects other aspects in addition to 3-hydroxylation. It affects collagen folding and collagen cross-linking in addition to modification. And altogether, the group with recessively inherited defects in 3-hydroxylation. You'll hear different percents. I would say 8 to 10% of OI cases in North America and Europe. Elsewhere in the world, for example, India, this percentage is much higher. I'm just going to mention the 2 other sets of genes without going through them individually. Each of these types affects quite a small number of people. If you have one of these conditions in your family, please feel free to reach out to me. I would be interested in talking to you. So one of these groups particularly affects collagen processing and cross-linking, and then the most interesting group affects the maturation of bone-forming cells called osteoblasts. My bias is that everyone with OI should know their affected gene and mutation, but this does arise from my mindset as a geneticist. I think it's good for you to know for family issues, potentially for studies on treatments, what research might be relevant for you. Knowing the mutation will also contribute to the advancement of the OI research field. That will teach us the range of symptoms for a particular gene. It may lead to the discovery of important new knowledge. Quite a few single patients have turned out to be the key clue to a great. I still want to go through a brief final section on management, and hopefully there'll be some time for questions. This is my view of who you might have as your OI team. Genetics first, of course. Pediatrics, internal medicine. You do need rehab medicine and physical therapy on an ongoing basis. To the extent possible, you want people with OI expertise. I know this is not possible in some communities, but then your local team should be willing to reach out to the experts, and so should you. For example, you may need a local orthopedist for setting fractures, but you might need someone with more OI surgical experience for roddings and spine surgery. Depending on severity, you might need a neurologist if basilar invagination becomes an issue. I personally think that periodic pulmonary function tests are not a luxury, given that respiratory issues are the major cause of morbidity and mortality in OI. So seeing a pulmonologist every few years is reasonable, and then more frequently if there's a problem. You might want to see an endocrinologist because they might be managing your anti-osteoporosis drugs or a growth issue, and those with dentinogenesis imperfecta or bite issues may need a specialty dentist. And what are the goals of all this medical contact? Well, I would say function first. Developing and maintaining motor skills as allowed by your type, to keep as much mobility and self-care skill as possible for independence. I've been so impressed as my group of patients grew up and lived independently at college and then established independent lives, sometimes requiring home health aides, but independent nonetheless. Of course, there's also a goal of reducing fractures, partially based on the behavior of parents and children, and partially on timely orthopedic procedures. Consider drug treatment. Most commonly today, this would be bisphosphonates. The goal here would be to increase both bone mass and quality, but the treatments so far really only increase bone mass. More on this in a second. Growth can be augmented in most type 1 OI children and in about half of type 4, and some type 4 children have attained standard growth curves. But there are limitations on the age and duration of administration. You need to consider how many inches you might actually get and what you'd have to do for them. This is a positive effect on bone histology. Which brings us to bisphosphonates. My position on bisphosphonates has been and remains the same. I do see bisphosphonates as having some benefit to offer, which is why I have treated children with bisphosphonates, but I advocate what I call a measured approach to the timing, to the dose that's used, to the number of years of bisphosphonate treatment. So what are the bisphosphonates? They're a class of drugs with the backbone of a naturally occurring substance called pyrophosphate, but then chemically different side groups, these R groups, are added and they give it its potency and its level of binding to the bone. So what's the difference between drugs you've heard of, alendronate, pramidronate, zolendronate? It's that they have different side groups. And the parent compound binds to the mineralized surface. So the parent compound becomes a kind of hook. It deposits the drug selectively on the surface of bone, and it remains there for years. And this graphic shows the basis of bisphosphonate mechanism. Here's the drug sitting on the bone surface under a newly mineralized bone, and osteoclast, whoops, over here, sorry. Osteoclast ingest the drug. It's like taking in the Trojan horse. It inhibits multiple osteoclast functions and eventually promotes their death. Well, osteoclasts are the bone resorbing cells, remember. So if osteoclasts are inhibited, then more of the bone deposited by the osteoblasts can stay around in bone. Say you have a collagen mutation. The bone forming cells are still depositing the mutant collagen. That's not affected by the drug, but the high turnover of bone with its cycles of rapid deposition and resorption, that is what is inhibited. So the idea is that you get to keep more of the bone that you make, but it still contains mutant collagen. When we treated our mouse model for classical OI, the brittle mouse has a dominant collagen mutation with bisphosphonates, you get some insight into what happens. So talking about increases in bone mass, it's quite dramatic. The trabecular bone increases dramatically. The cortical bone becomes thicker, and this happens in both mutant and wild type or yes. No, sorry. Okay. Everything has a reverse side to the coin. So concomitant with this desirable increase in bone mass, the bone is retaining mineralized cartilage. You can see here by the green zones, and here on this method of viewing it by the whiter zones. And this now makes inhomogeneous bone matrix. And in an engineering sense, this weakens the bone. And bone forming cells, these nice plump square osteoblasts here and here right along the surface of the bone. After extensive treatment, they become kind of flattened and exhausted. And all of us, as we use our skeleton, develop little micro cracks. And if your osteoclasts are so inhibited that they can't repair the micro cracks, then there's an increased risk that a small crack could propagate into a fracture. So how to achieve this balance? You want the increase in mass, and unfortunately, what comes with it is some change in the matrix quality. And so we have advocated for use of pramidronate, but at a lower dose, which I think a number of people are now doing, can be quite effective. I think the time range that the drug is used, our plan is 3 to 5 years of drug, and then watchful waiting, because the effect lasts for quite a long time. And with pomidronate, we have been spacing the drug to 6-month intervals. I know people who are on Zol may be getting it once a year. These are kind of, so there's a little areas of discussion on bisphosphonate, and these are the areas of general agreement on bisphosphonate. From both studies in Montreal and at the NIH, the maximum benefit for bone histology is achieved in 2 to 3 years of treatment. Everyone agrees that the bisphosphonates are really quite effective in repairing vertebral compressions. Unfortunately, the long-term, and that's a good thing. Unfortunately, you won't get a decrease in the incidence of scoliosis in treated and untreated children, and you'll still require generally is an area of controversy that you should discuss before you initiate drug on whether long bone fracture rates are significantly reduced. In blinded studies, there was no significant change in the independence of ambulation, in the strength of muscles involved in ambulation or in pain. That's another area of great controversy. Some people swear that bone pain is changed. So overall, this class of drugs was developed. Keep in mind that this class of drugs was developed for postmenopausal osteoporosis, not for children with a genetic defect of bone, but there weren't a lot of options. So the drug was repurposed, and its outcome in children has benefits to offer, but they require careful decisions on the use of the drug. Now on the horizon is a group of drugs with bone-forming action, stimulate osteoblasts to make more bone, as opposed to the action of bisphosphonates, which is primarily inhibitory. These drugs are short-acting. They don't hang around for years. They don't, therefore, inhibit repair of microcracks. They're available for osteoporosis, but they're just coming into testing for OI, and these are antibodies to compound protein called sclerostin, or antibodies to TGF-beta are the most promising. I don't have time to talk about them in this talk, but you would do well to inform yourself. And finally, my last slide, I want to briefly mention that your child can be involved in natural history programs for OI. At the NIH, we have a longitudinal program for OI children that we've had for decades. This started out for collagen-based OI and now includes rare forms. For this program, you need to enroll by age 12, and then we can follow you throughout life. If you came to the NIH years ago as a child, we now have the ability to see you as adults, which we didn't have before. We had to graduate you. And our interest is in how OI progresses from childhood into adulthood. What early signs of later complications can be detected in childhood and therefore dealt with earlier. So you get access to OI expertise at no charge to the family or to insurance. There's a travel and a housing program to hear all of the evaluations that are included, and of course all the results will be shared with you. And there's also a consortium, separate from the NIH, there's a consortium of 12 academic centers in the US where some similar evaluations are offered, and you can talk to the OIF about that option. And finally, here's my lovely lab group gathered in the hallway around, I believe she's actually on the call, around a patient who is a great example of how one patient can dramatically change our understanding of metabolic pathways in OI and the relationships of rare types to each other. And as usual, I've gone over, but I think there still is some time for questions.
Dr. Marini, thank you so much for this incredibly informative, thorough, excellent presentation. I have heard many versions of a basics of OI talk before, and this has really been so clarifying, and actually even I have been learning a lot on this call. Thank you so much. I want to remind the audience, so we've got about 15 minutes or so before we have a hard stop time for this session, because we have another one afterwards. So we're going to try to answer as many of your questions as possible. Also a reminder that this session is being recorded, and we will post it publicly online after the virtual conference is over. So if you feel like you missed something, you will also have that resource later. So with that being said, Dr. Marini, I'm going to just start jumping in if it's all right with you.
Hey, Michael, this is Tracy. We're having a little trouble hearing you. Can you get closer to the microphone?
I'm sorry. Yeah, let me speak a little bit louder. I was just saying this is going to be publicly recorded and posted online afterwards. Can you guys hear me better now?
Yes.
Perfect. Okay. So the first question we have is, Dr. Marini, how many diagnosed types of OI are there now in the world that we know about?
The classification that I showed you includes 18 types. Some would say, I think we're really running out of types. Not to fear, there won't be 100 types. And the way we know that we're running out of types is that those of us who had freezers full of samples with an unidentified mutation have now been able to put an identified mutation on all but there are a couple of genes in the waiting areas that were first reports that may need further features clarified. So 18 to 20. There won't be much more. The genetic identification of OI is substantially done, and what is found won't affect many patients because there are very few left whose mutation can't be identified.
I see. Thank you. We've received a couple of questions around human growth hormone therapy.
Oh, yes.
And I want to know, what are your thoughts regarding human growth hormone therapy for OI children?
I think it has to be discussed very carefully on an individual basis. First, there's an issue of responsiveness. It's hard to predict, and I would have this conversation predominantly with type 4, and the Italians have done a lot of studies on type 1. What age are you? How many inches do you hope to gain from going through all this? Sometimes a few inches can make a big difference in activities of daily living in terms of being able to reach certain things that are placed at a certain height for the rest of the world. Unfortunately, we can't now predict from preliminary tests. We can say, okay, the results of such and such a test are 70% predictive. That's nice, but not great. Unfortunately, we don't know until someone has had, say, 6 months of treatment, whether or not they're going to be a responder. And then even the responders tend to gradually blunt their response so that you might remain responsive for 3 years, 4 years, something like that. If there's very severe popcorn, you're probably not going to be a responder. I don't see it as, I think it can be useful selectively.
Great, thank you. Another question we have is, people are asking about your opinion about the possibility of treating OI in utero via gene therapy. And possibly a related question is CRISPR a thing that could possibly?
Okay, let me start with the CRISPR.
Sure.
It would have to be something for the future. Right now, the trouble with CRISPR is that it often has what we call off-target effects. So you may achieve the change that you're gunning for, that is changing the mutation that you're targeting, but you may find that you have also added other undesirable changes. CRISPR is under kind of rapid, that whole approach is under rapid development to decrease off-target effects. I don't think it's out of the question that CRISPR might well hold some prospects for the future. Gene therapy in utero. So there is a program in Europe, in Sweden, I believe, and maybe there's some collaborators in Germany and elsewhere that are attempting stem cell therapy in utero. I have my concerns, but mostly I would like to be able to know whether or not that's really effective. And if you simultaneously treat the child when it's hard to know with all the variability of OI, what a particular outcome of one child means. And then if you automatically treat that child with a bisphosphonate, how do you separate the contribution of the cell therapy and the bisphosphonate therapy? Recently, there have been some rather exciting data in mouse models about cell therapy and getting bones to take up a much higher percent of normal cells when the normal cells are locally injected literally into the marrow cavity of the bone. Unfortunately, those animals had to be irradiated, so there's a lot to be learned there. But let me just say in general that nature has already shown two good ways to make OI much milder. One is the mosaic parent who hardly has any symptoms at all. And if you could achieve good cell therapy and get enough cells to be taken up, then maybe a patient could become a sufficient mosaic with. And then the second great way nature did it was the way that you get type 1 OI, where one of the genes for type 1, for the alpha-1 chain has been turned off. That's what's happening in type 1 OI. They're much milder. I know they have problems, but they're much milder than types 2, 3, 4. So if you could turn off the mutant gene copy, then you might not need the individualized CRISPR approach. You could simply turn off the mutant copy and go from being, say, type 3 to type 1. So a lot of therapeutic possibilities are coming with new technologies. They're just not ready.
Great, thank you. So we've got a series of more specific genetics related questions. One is, will OI type 1 show on an autosomal dominant OI panel test for collagen 1A and A2?
Yes.
Excellent, easy.
Yes.
Then the next question is, does a BMP1 mutation have to be homogeneous to have clinical features of OI?
generally, so this is an interesting question. Generally, for any of the recessive types, you do need to have two mutant copies of the gene to cause features of OI. Whether they need not be identical copies of the identical mutations, but you generally need one in each gene copy. That's called a compound mutation situation. People have been looking to see, now that the panels are done, we're turning up other sequencing panels are done, we're turning up other cases where patients may have a pathological mutation in one of the recessive genes, but only in one. And they may also have a collagen mutation. We assume the collagen mutation is the causative one, but to what extent can a recessive mutation contribute as a modifier? I'm making the question, I guess, or the answer more complex, but generally for BMP1, you need to have two genes.
Thank you. So the next question is, can OI be diagnosed in a zygote? I may be pronouncing that wrong, I apologize.
Can OI be diagnosed? So if you, I think where this question might be going is that if a parent has OI, then you can do, and you know the mutation, then you can do chorionic villus sampling quite early to determine whether or not the fetus has inherited. And another situation in which OI might be diagnosed in a zygotic developmental stage is if you were doing in vitro fertilization to be able to select embryos that did not carry the mutation, then a single cell can be removed very early for testing from each embryo, very, very early, where it wouldn't cause deformity. And then embryos containing the mutant cells would then not be implanted, and the embryos that didn't have mutant cells would be. This technique is much more commonly used in Europe than in the United States, but I have had inquiries in recent years about this technique.
Excellent, thank you. As you can see, I actually just switched out our slides. I wanted to just quickly, we have 1 minute left, so we're gonna try to quickly answer one question, but also want to include a quick thank you to our sponsors, Swoop, and for some reason my computer is being a little funny. So the last question I have is around respiratory issues.
Oh, yeah.
So this is not specific to this talk, but also I think it's a very good theme. You brought up the idea that like respiratory or cardiovascular complications is the #1 or one of the main killers of people with OI. We had a couple questions around, does respiratory issues also affect people with more mild OI, like type 1?
So the basis of saying it's the major cause of morbidity and mortality, we've known this for years, but then a very nice Danish study was done where the population has a complete registry of birth in the country, and a very nice study was mortality. I can't really tell you about type 1 because the studies that we've done have all been with types 3 and 4. I can tell you that there are declines, this is published, there are declines in pulmonary function tests, even in those without scoliosis, with collagen structural defects that occur during childhood. So it can start before it's even suspected. I've seen no comparable studies on type 1. I know that the foundation is working with Dr. Raggio and Dr. Sandhouse, and perhaps that consortium will produce that data on type 1. I don't know it.
Okay, thank you. So, Dr. Marini, we are now unfortunately at time. I want to thank you again so much on behalf of everyone on the call. We have over 200 people joining us from around the world. Thank you so much for your dedication to the OI community, to the OI Foundation, to your patients. We are indebted to you and all the work you've been doing. To everyone who is joining us on the call, thank you so much. We know we're not able to answer all of your questions today.
Michael, if I may say, my people may have noticed that my email was on one of the slides. Those who write to me may tell you that I'm a slow responder, but I do get back to everyone eventually.
We want to also welcome everyone, and we hope that you'll be able to join us for other informational sessions throughout today and tomorrow. And with that being said, thank you so much, and we will see you again soon.